Alright, so this is for chapter 13, which is kind of collagen stuff. And this first one is lichen sclerosus. And this one shows a lot of the classic features, so it's a pretty good one, although it has kind of the super old slide sign up here. So what you see in lichen sclerosus is this kind of pink, somewhat compact stratum corneum, and then usually a very thin and effaced epidermis that's kind of pale, and then particularly a pale and somewhat homogenized papillary dermis. And then, not always, but classically you'll see this lichenoid blue lymphoid band down below that area of homogenization. So it's kind of lichenoid. It's not technically interfaced like right at the DEJ. It's more pushed down below that area of homogenization, and that's what gives it the what we call the red, white, and blue sign. So you get the red, the white, and the blue, and that's classic lichen sclerosus. Now there's a couple other clues here. Lichen sclerosus can of course be extragenital. You can get it in the chest, back, and elsewhere, but usually it's in the genital area. And here you see kind of this thin not so, kind of more loose stroma, lots of vasculature. There's probably some smooth muscle bundles in here and nerves and things. There's a nerve. So that speaks to it also being genital skin, and that can sometimes help you as well if you're looking at this and thinking other things. And the reason why you would think other things is because a lot of things can look like lichen sclerosus, or there can be some overlap and some similarities, and we'll go through that with some of the other slides. But chronic radiation dermatitis and even superficial morphia, a lot of those things can look very similar. So just getting down a little bit further, you can see that compact stratum corneum. Lichen sclerosus can be pretty hypertrophic. And sometimes it can be a little confusing because you don't have this very thinned epidermal layer, and instead you have a little bit of acanthosis because of scratching. Lichen sclerosus can be very pruritic, and so if you scratch the heck out of it, you're going to get some secondary lichen simplex chronicus changes, and so that can, when you have a little bit of both going on there, it can be a little bit confusing. But you have that compact stratum corneum, thin layer of the epidermis. And you may even have some true subepidermal split here, by the way, and you can get bullous lichen sclerosus. And so, this also could just be processing artifact, but that would be where the split would occur. And then there's that pale, homogenized papillary dermis with that blue kind of lymphoplasmacytic infiltrate underneath. And that is kind of textbook lichen sclerosus. So the second one is Elastosis perforans serpiginosa, or EPS, and this is where it's basically a perforating disorder of elastic fibers. And this can be seen in a lot of different conditions. You guys memorize the different acronyms. Most people will use the RAP moped acronym. There's other ones. I kind of altered it to say crap moped because you want to include cutis lax in there, but that includes things like Rothman-Thompson and acrodermatitis and osteogenesis imperfecta and PXE and Downs. I mean, there's a lot of different things in there, and that's why it's good to know that acronym, because they may show you this slide on the boards and then have more of a question of what could this be seen in. And so the classic features are a fairly focal area of acanthosis, and then something that's sort of obviously, perforating through the epidermis. And when you compare EPS with reactive perforating collagenosis or acquired perforating collagenosis, EPS is usually more tortuous or serpiginous. It's not always the case, but it often is, where it's sort of more tortuous coming through the epidermis, whereas a perforating collagenosis is usually more cup-shaped, and there's a great example in here. And of course you can stain for it as well, and that can help delineate between elastic fibers and collagen fibers. But either way, it's a perforating disorder. From this, at scan, it may just look like a bunch of newts. So obviously you'd have to kind of get in deeper and show that it's not just pseudoepitheliomatous hyperplasia with neutrophils or a bunch of eosinophils like in P. vegetans or something. But it's not affecting the whole epidermis. It's really just affecting this little focal area. And so from scan, you're kind of suspicious of something perforating. And then when you get in a little bit closer, there's not really a whole lot of infiltrate going on. It doesn't really look infectious. And then even from here, you can kind of start to make out these little tiny fibers. And these would be, those elastic fibers. Now, elastic fibers, we typically, here in the dermis, you can't just see them. If you get in real close, you can sometimes make them out, because all this red stuff is, of course, collagen. Usually you have to stain for the elastic fibers, but as they're being perforated in EPS, they kind of become much darker, thicker, kind of red. And so these are all elastic fibers. And again, you can stain for it to see, which is what the next slide is. So here, all these little elastic fibers coming through in this tortuous pattern, perforating. This is usually a good one on boards because most people can get this pretty easily, unless it's a very subtle case. So that's EPS. The next slide is just an elastic stain. So you can see over here all these elastic fibers, and then here you can see that cut where it's actually perforating. And so everything is staining black as an elastic fiber, and all this is filled with elastic. Sometimes it's hard that the stains aren't perfect, and maybe it's a little more cup-shaped, and so all the dermpath person can say is like, well, it's something perforating. We don't know if it's elastic fibers, we don't know if it's collagen, because sometimes as they're being perforated, they sort of lose their staining ability as they're being altered. But usually the stains work well. So again, lots of black elastic fibers perforating through. That one. Okay, now this one is labeled Morphia. That's the answer. I'll tell you, this certainly isn't the most textbook Morphia there is. And the reason for that is because up here, this certainly doesn't really look that morphiform yet, but this is probably very early Morphia. And there's a spectrum, as you guys know, between Morphia and scleroderma. They're certainly related. There's a lot of little weird variants like the Atrophoderma piscinia and linear Atrophoderma. There's a lot of the weird little variants that we like to memorize that we rarely see, but in true Morphia versus scleroderma, Morphia is usually a little bit more inflammatory, so you definitely see lots of inflammation here. It's not usually this much, though, and usually you get more of that square-shaped punch, and the whole thing is kind of this dense, thick collagen bundles that's usually fairly posse inflammatory. And when we say that Morphia is a little more inflammatory than scleroderma, usually we're talking about kind of this deep component here. So this is something more that I would expect to see in a case of Morphia, this kind of lymphoplasmacytic infiltrate that's usually at the dermal subcutaneous junction. So all this inflammation is a hint unusual, but it still definitely goes with Morphia, and more with Morphia than with diffuse scleroderma. Where you can see that dense collagen is all down here. So maybe this is Morphia profunda or deep Morphia. That's probably where this is going and what this will be classified as. But you can certainly see even from scan, these collagen fibers here do not look like these collagen fibers. These are really thick, a little bit homogenized. With time, this whole thing will just kind of get homogenized in a big square area. So it's looking morphiform. Now there are other conditions that can cause morphiform appearance, GVHD, scleroderma or GVHD, other things that you don't want to keep in differential. But if the clinical said, hey, this is a small area that's looks kind of dense and firm and morphiform, then there you go, you got the clinical pathologic correlation. Now, if you get down in deep and you look at these, this infiltrate, it's probably going to be full of mostly lymphocytes, but also plasma cells, and that can be helpful versus seeing, if all this was tons of neutrophils or tons of eosinophils, that wouldn't really go as much with Morphia. Now with Morphia, you can get some overlap, as I mentioned before, with lichen sclerosus, Not as much here, thankfully, but there's maybe a little bit of some homogenation that's occurring. Now with Morphia, though, usually you do not get any sort of vacuolization of the basement membrane. You don't really get as much of that compact stratum corneum. And of course, there's a whole lot of stuff going on deep here that you wouldn't really get with lichen sclerosus. But a lot of people believe that lichen sclerosus is kind of a very superficial variant of Morphia, or at least they're related, and it's hard to really tease that out, but they're at least related. Okay, number 4. This is always going to get on a test. Usually from scan, this is pretty easy to get. This is Ochronosis. And usually it's not going to be that simple. They'll be asking more about what's happening, what is the patient using, or what is their genetic defect. So, most commonly Ochronosis we see is from excessive amounts of hydroquinone. Usually it's the stuff you buy from Mexico that's like 20% versus the over-the-counter 4% or 2%. And you can also get it from phenol, and you can see it as a genoderm in alkaptonuria, which is a defect in homogenistic acid oxidase. So all those things are good pearls to remember for the boards, but in terms of the path world, you see it, it's easy, it's awesome, Ochronosis. Okay, so this one is eosinophilic fasciitis, and of course I'm sure Dr. Ellison today will mention how it's one of those things where you don't necessarily see the eosinophils. You may get not a single eosinophil within the entire process in the skin because it's more of a peripheral eosinophilia. However, that does not mean that you will never see eosinophils, and if you search through this, there are very rare eosinophils in here. But from scan, what's kind of maybe leading you down that route is there's this big, huge hunk of tissue that someone probably did like an incisional biopsy or excisional biopsy from. And there's it doesn't seem to be a whole lot going on in the epidermis or even the dermis. This is probably from, all these holes are probably just from rapid infiltration of the lidocaine. But there's definitely something going on down here. But it's not really a paniculitis because all the fat looks pretty normal. There's not, the infiltrate is not really getting into the fat. There's not a lobular paniculitis at the very least. But maybe with this septal thickening, maybe it could be EN, so more of a septal paniculitis, but it still isn't really appearing like that. You don't have these large giant cells. You don't have the infiltrate that you would normally see. Here you do get more of this diffuse infiltrate, and it's kind of mixed. So you do get some inflammation, but it's not a granulomatous or a paniculitis-like infiltrate. Here instead it's going to be more just a mixed infiltrate of some rare lymphocytes and some neutrophils maybe, and then some rare eosinophils that are just sort of loosely spread along this very much thickened and kind of sclerotic fascia. And when you combine that with the clinical of the dry riverbed sign or different things that hopefully the clinician is trying to pick up on, that goes with eosinophilic fasciitis. Okay. So this is a keloid, and if you look at this slide at 1x, it's this big round thing. You could imagine this probably being cut off someone's earlobe or something. And clinically, what makes a keloid, of course, is that it's a scar that's growing past the original area of injury. On the derm path side, what makes it a keloid is these, bubblegum collagen, as people like to say, keloidal collagen. And you can have one without the other. So you can clinically have a keloid where you really just don't see a whole lot of the keloidal collagen under the microscope, and vice versa. We see keloidal collagen commonly, but it doesn't necessarily mean it has to be a keloid. In terms of the diagnosis clinically. And what you do see here is, in addition to that keloidal collagen, is you see a background of hypertrophic scars. So these big, huge, thick whorls, a relatively bland collagen with some little dots of fibroblasts and things in there. And from scan, you might be wondering, what else could this be? Could this be a angiolymoma or pilolymoma or some sort of smooth muscle thing? Could it be some other soft tissue process? But all these are very bland. It doesn't quite look like a fibromatosis or anything else, and the clinical can certainly help you too there. But then when you see this keloidal collagen, this is really what kind of helps to say, oh, it's hypertrophic scar, keloidal collagen, that really fits with just a run-of-the-mill keloid. And again, you can't see that in other things. Most classically, dermatofibroma, the periphery, we see those collagen ball trapping, and it's often keloidal. So this is that cup-shaped focal process of reactive perforating collagenosis or an acquired perforating collagenosis. So a little bit different than that tortuous appearance of EPS. And, of course, for it to be a true reactive perforating collagenosis, that's more the genoderm you see in kids. Otherwise, more commonly, we just see what is better termed an acquired perforating collagenosis in someone who has usually diabetes, renal failure, that type of thing. And so that cup-shaped appearance certainly can be a clue. You can kind of see that sometimes in other things, like CNH actually often has this sort of cup-shaped appearance, even though it's not really a perforating disorder. But this is usually pretty easy to get at scan. I mean, there's nothing else going on in the periphery. There's not a huge infiltrate, so kind of like EPS. Now, you would want to look at the base of this, make sure you don't see any weird organisms or something infectious. But even here, you can start to see some of the collagen that's sort of breaking down. Unlike EPS, a lot of times you don't get very well-defined fibers because they're all just sort of being chewed up and spit out. And there are neutrophils and things in here, which is, again, why you want to make sure it's not infectious. And if you stain this, you might see some actual fibers being extruded. This fiber here, for example, is probably an actual collagen fiber. But you'd stain for this, you'd match it with the clinical, and that would go with an acquired perforating collagenosis. And we've had some of those recently, actually, so they're not that uncommon. So this is number 8. This was labeled AKN, and some of the clues for this one, at least for the derm guys, when you see this, you can sometimes get a little overwhelmed with the amount of tissue, but that's actually a clue that it's AKN. Because on a test, when you get this huge excision of tissue, and it kind of just looks like scar, I mean, there's really just a lot of background of scar here. You got vertical vessels and all this sort of thickened collagen, but not much else going on. That's a clue that it's AKN. And what you would ideally find is a little bit more neutrophils than what you see here, so which makes you think, is this infectious? And then naked hair shafts. Now, I'll tell you, earlier this morning I was searching in this for some naked hair shafts, and I couldn't really find any. So it could be very, very burnt out AKN, which is why it's not as neutrophilic. Because usually with AKN you see a little bit more of all this going on. It's more of like a suppurative folliculitis that's sort of diffusely spread throughout the scar tissue, and then you find some naked hair shafts. So finding those naked hair shafts is pretty key, but if you don't see it, and an answer choice was AKN, you just have this huge excision of scar, then it's certainly a good thing to pick. And that's really it for this one. Okay, number 9. So this one is radiation dermatitis, and this would be more chronic radiation dermatitis. Acute radiation dermatitis is usually pretty subtle. You can get a little vacuolar basement membrane damage, interface, but what you actually don't really see that very much with chronic radiation dermatitis. This is usually more late appearing, months or years after an extensive chronic radiation, and the clues here are that it can appear similar to lichen sclerosus, similar to Morphia. It's kind of on that differential for this homogenized dermis and this, like anything that looks morphiiform. But the clues are these wildly ectatic vessels, particularly superficial. Deeper, they're usually thickened, actually, from all that kind of chronic damage. But superficially, these huge ectatic vessels is very much a clue. The epidermis itself is usually very much effaced and thinned and loss of the reedy ridge pattern. You might get a little bit of flicker plugging, which again can make it look similar to lichen sclerosus. And then the other thing you want to look for, and of course, there's that just sort of homogenized, morphiform dermis. But the other two big things you look for are a lack of adnexa. So all that radiation usually kills off pretty much all the adnexa. So you don't see a ton of eccrine glands here. You don't really see any follicular structures or pilosebaceous structures. Certainly no sebaceous glands. They're all gone, and that's a clue. And then what you may still have retained, a lot of times the piloerector muscles are retained. And so sometimes on a test, the examples can be pretty striking, where all you see is like one long piloerector muscle and then these widely ectatic vessels, and that's it. And that would be pretty good for radiation dermatitis. The other thing you can see is stellate fibroblasts. That's not 100%. And I was looking through this earlier. There's not a whole lot of great examples. I think I found like one here. This little guy. Usually they're even bigger than that, but that's probably a little stellate fibroblast. Let me just get it on the screen. So that little guy there. So that can be helpful, and that's pretty much it. So those are the kind of the key features of radiation dermatitis. This one is colloid milium. Now, the most common colloid milium that we see is really sort of end-stage severe solar elastosis. And you can see why. I mean, it's pretty similar to just that homogenized, slightly bluish, degenerated elastotic material that we see with solar elastosis. Colloid milium is usually, very much collected in the papillary dermis. It's almost like it's breaking apart. It's kind of this fissured, amorphous material, so fairly acellular, and that's how you can distinguish it a little bit from things like lipoid proteinosis or true amyloid. This is probably a little bit related to amyloid, and in fact usually stains weakly for more keratin-derived amyloid stains like crystal violet. And so it may be a little bit related. There is the genoderm colloid milium, where it's more, you see this in kids, and maybe that's what's going on here. I mean, this is pretty acre-looking skin, so maybe for whatever reason this is more of the genoderm variety, but it's hard to say. Either way, it's all those things I mentioned, that kind of homogenized, fairly acellular and fissured, kind of breaking apart, appearing slightly amphiphilic material. So that's colloid milium. And speaking of solar elastosis, this is Favre-Racouchot syndrome, or what is it, nodular elastosis with comedones. I always forget the order of those words, but basically this is what we see, not that uncommonly, on particularly the cheeks, periorbital area of people with lots and lots of sun damage. So your farmers, people that we see frequently in clinic. Smoking absolutely increases the chance that we're going to see this in someone. So chronic smoking, chronic sun damage, patients start to get those kind of open comedones, little milia, tons of solar damage all around the eyes. And if you biopsy it, this is what you see. So background of tons of solar elastosis. So this is, over here, kind of that classic solar elastosis, a little more nodular. And then you see these large cysts, and these are on the scale of milia. So again, milia are basically more of a clinical term, and under the microscope they're just these really, really tiny infundibular type cysts. So they're basically like little tiny EICs, which is usually how we code them clinically when you're doing like milia extraction. But so here's all the, that solar elastosis, milia, it's on the face, lots of sebaceous glands. This is kind of fits with what you see clinically. Okay, so this one, flip this around. me just make sure. But this one I think was also lichen sclerosus. Yep. And this one's a little bit more of a subtle version of it. And from scan, you may not get to that right away. It doesn't have as much of that red, white, and blue appearance. But when you get in a little bit closer, you can start to make out some of those classic features. You've got a little bit of this kind of pink, compact orthokeratosis of the horn. Certainly you have an effaced, kind of thinned epidermis, so effaced meaning that the reedy ridge pattern is essentially obliterated. You have a little bit of this vacuolar kind of interface, and then it may not look initially lichenoid because you don't have this huge blue lichenoid band right at the DEJ, and instead you have this more homogenized papillary dermis with some pigment incontinence. So there's definitely something going on in the DEJ, some more of this chronic smoldering thing, and then below that homogenized dermis there is a little subtle layer of blue here, and so sometimes lichen sclerosus can be very subtle, and you kind of have to search for all those features to make it, and this is one of those where, in my opinion, there's never any shame in going in closer. There's some things you have to do that on, and then there's other things where there's no reason not to do that if you can. So maybe you can get it at scan, but if you get in closer, you can really start to kind of make out those features, the homogenized papillary dermis, so pigment incontinence, and vacuolar damage that's been just sort of smoldering. So that's lichen sclerosus. 13. So this one is CNH, or Chondrodermatitis nodularis helicis. And this one is, of course, the one you'd want to get on a test because there's the cartilage present that, in the derm land, we don't see a whole lot of cartilage usually with our path stuff. So if you see cartilage, you think, oh, it must be CNH. Now, in the path world, you see tons of cartilage all the time, and so you get a little bit more used to seeing it. And the reason why I bring that up is because on the boards, they may give you a cut that doesn't have cartilage there. And even though that sounds scary, usually you can still get to CNH because it has some fairly characteristic features. Usually there's a little bit of acanthosis kind of around this very focal, sort of cup-shaped appearance, almost like that acquired perforating collagenesis. So it's usually this very focal area of degeneration of the epidermis, and then what also helps is this little area of fibrin underneath, so this little area of kind of this reddish pink stuff. And there will be usually some neutrophils in there. I mean, it's kind of this erosion on the skin that you guys see commonly, and so it can get secondarily impetiginized pretty easily. And so you may think, oh, is this infectious or something? But it's usually just very superficial. It's not this deep neutrophilic infiltrate. And it's not, squamous cell carcinoma. I mean, that's the reason why we biopsy, of course, is to not only treat it, but to make sure it's not a squame or something. But this epidermis looks very bland. There's nothing going on. There's really no atypia. There's no disordered maturation. It's just normal skin, but with an area that's broken down. This is essentially a very focal, small pressure ulcer on the ear. Having this huge lobe of cartilage underneath it certainly is helpful and will absolutely help you clinch the diagnosis when you see, just over this little area of degeneration. Just quickly getting a little closer in. Yes, there's some newts up here, but they're really just up in the sternum corneum. This focal area of dying skin, fibrin, cartilage goes with CNH. Okay, 2 more. This one is the Borrelia associated Acrodermatitis chronica atropicans, which is sort of a frustrating diagnosis because we don't really see it that often. It can be very subtle and hard to pick up on. It's absolutely in the differential for things that are a little bit sclerotic, a little bit of face, kind of damage to the collagen. We don't see it as much over here because it's more common with Borrelia afzelii, which is the more prevalent in the European borreliosis. But we still have to know about it. And how you get to that diagnosis is you see this sort of effaced epidermis. So there's something atrophic going on here, and that would be the atrophic part of that long word. And then there's it's not quite morphiiform, although it sometimes can be. But instead, you do see, even from scan, and I'll get closer, this sort of diffuse infiltrate. But the infiltrate is not really accentuated around any particular thing. So it's not really periadnexal, periacrine. It's not really a lichenoid band per se. It's more what we call this sort of diffuse polka dot appearance. It's sort of diffusely spread over the entire biopsy. And so there is sort of atrophy of everything else. There's not only epidermal atrophy, but there's often sort of dermal atrophy. You can have a higher subcutaneous fat layer than normal, almost like you would think with nevus-lipomatosis or something of that nature. So in other words, the dermis can get atrophied as well. And then that little bit of fibrosis that occurs, almost this fibrillary fibrosis that you see in the background of all these very much attenuated collagen fibers, kind of dispersed amongst that is all this lymphoplasmacytic infiltrate. And I know you have to put on your dermpath goggles, but this is sort of a very much regularly distributed polka dotted appearance, almost like what you'd think with like a mastocytosis. How they're all sort of evenly spaced. In a sense, it's kind of like that, and instead of it being in clusters or focused around different things. So you can get a little bit of vacuolar degeneration too, which you see at the top. It's not really an easy diagnosis or a fun one to get, certainly on the boards or anything, but it does have when it's well developed, it has pretty characteristic features. And then this one kind of threw in because it's sort of an overlap diagnosis. We talked about it last block in the genoderms, but this is PXE. And usually this is a good one to get on test too, just because you see all this calcified, fragmented, elastic fibers. Sometimes it gives more of the bramble bush appearance if it's more penicillamine induced, but they all look pretty similar. All the different things that cause PXE. Of course, there's the actual genodermatosis, but there's some other things that can cause that appearance. So this is PXE. Any questions, or you want any particular slides anyone wants to see again? Cool. All right.
Thanks.
Yep. No problem.
For the acrodermatitis